So welcome. We are the Life and Breath Foundation, and we are here to support sarcoidosis patients on their journey. Our goal is to empower sarcoidosis patients however we can. And so the webinar tonight is one of those things that we do where we're trying to bring in experts in any way that will be able to support a sarcoidosis patient on their journey. So we do have these monthly speaker series. We have a Life and Breath Scholar program where we're working on educating future physicians. We have a patient support group, sarcoidosis experts that support patients, and we have a planner called the My Life and Breath Planner that is a roadmap for sarcoidosis patients. Our speaker tonight is Dr. Paula Barreras. She is a board-certified neurologist with an expertise in neuroimmunology. And I'm sure I did not say that correctly. And she comes with many, many recommendations. She has been on our speaker series before, and we just loved having her. And she was gracious enough to come back tonight and discuss more small fiber neuropathy questions. And there are so many of you that registered. There are so many questions we got. And then, as you know, the internet is against us tonight, so we will do what we can do, but we're so excited to have you, Dr. Barreras. We're so excited to be here. I did want to do a quick disclaimer. Dr. Barreras will answer what she can and talk about what she can, but she is not your physician. This does not establish any patient-physician relationship. She is not your doctor. She does not know the specifics of your medical history or anything that's really going on. So anything that she says, please confirm and talk with your doctor before making any decisions off of the information that you will hear tonight.
All right.
So,
Well, thank
go
you,
ahead.
everyone. Hopefully, you can hear me and see me now. Like we said, I'm going to be talking about small fiber neuropathy in sarcoidosis. At Cedar Sinai, we do have a multidisciplinary sarcoidosis centers. If you ever need a second opinion or want to establish care in the California area, we're in Los Angeles. So, so let's start by talking about neurosarcoidosis. So neurosarcoidosis is the involvement of the nervous system. So when sarcoidosis affects the nervous system, and that could be the brain, the spinal cord, or the peripheral nerves. And I put a highway there because the nerves are like a network of roads. You can think about it as the roads that take the signal from the brain to your skin or from the outside world to your brain. So if there is a problem in those roads, a roadblock, let's say, then the signal cannot go through and you may feel numbness or may feel weird things in the skin. And that's a little bit what we're going to be talking about next. So small fiber neuropathy. So let's break that term a little bit so we're in the same page. So neuropathy just means a problem in the peripheral nerves. And we, just said that the peripheral nerves are taking those signals in and out to your brain. Now, those nerves come in, let's say, different categories. The large fibers have some functions, and we're going to focus today in the small fibers. So the small fibers are the ones in charge of pain and temperature sensation. So those are the ones that take pain signals from the outside world back into your spinal cord, and from there, spinal cord takes the signal to the brain, and temperature and autonomic fibers. So we do have an autonomic system that controls our heart function, like heart rate, or controls our blood pressure, how dilated your pupils might be. And those fibers are also in the category of small fibers and can be affected by this issue. So now, because now we know what the small fibers do, we can understand why the symptoms are so varied and so diverse. So 80% of people that have a small fiber neuropathy have what we call neuropathic pain and paresthesia. So what that is nerve pain in a distribution that is very patchy. Usually is like in the picture you're seeing, in the hands, in the feet, more proximally in the body, but it can be quite patchy and often affects the center of the chest, the upper back, or the face, manifesting as either facial pain or headaches. And because those fibers can be, the fibers of the autonomic nervous system can be involved, in 50% of people, then that can manifest as arrhythmias, as palpitations, issues with digestion, where the stomach, the nerves are a road. You heard the roadblock part, and how the nerves, the small fibers control pain, temperature, and autonomic function. And I was really focusing on this slide, which is how does that feel like? And in pink here in this cartoon, you can see the distribution of nerve pain and abnormal sensation. So it's usually in the hands, in the feet, can be a little patchy, can be in the center of the chest, in the upper back, or in the face with headaches. Paresthesias are that sort of tingling sensation, pins and needle sensation that can be in the same distribution. And because it affects the autonomic nervous system, it can manifest as arrhythmias, as fluctuations in blood pressure, as difficulty with digestion, bladder dysfunction, even sexual dysfunction, or abnormal sweating, so inability to sweat normally. This sometimes can manifest because the pain or the abnormal sensations are in the middle of the chest. Sometimes people think it's cardiac, end up in the ED multiple times. The cardiac workups are negative, and this is what we call atypical chest pain, but it can be just from the small fiber neuropathy affecting the skin in the center of the chest. And this is a sensory problem, meaning it's abnormal sensations. It's not a motor problem, so it should not cause weakness. Okay, so we mentioned neuropathic pain. So this is buzzword to say nerve pain, and it's the pain that is initiated by injuries of the nervous system, and that's different from the regular pain that we have when we injure ourselves, which is supposed to be protective. This is different. It's an inappropriate and excessive response to normal or mildly painful stimuli. So normal things now feel painful or feel burning or feel different, unusual, like you touch yourself and it feels like pins and needles. And this pain is different, and it does not really respond to regular painkillers. So some examples of how that might feel as a symptom, so you can identify it in yourself if it happens, is superficial burning pain, so feeling like a sunburn. Paresthesia, so we talked about that pins and needle sensations, and insect crawling, ant crawling sensation, tingling. It can feel like increased pain sensitivity in areas that you didn't injure. So just something that is a little painful feel more painful than it should. Or something that is not painful at all now suddenly feels painful, like a touch or your blankets may feel painful. Sometimes persistent and abnormal itching without a rash can be a type of neuropathic pain. So that unexplained itching is a potential symptom, or electrical shooting pain. Now, the consequences of this nerve pain are beyond just the pain itself. So if somebody has these persistent sensations, especially if they go undiagnosed and untreated, it's been described that this leads by itself to anxiety, depression, social isolation. It can have a negative impact in quality of life. It may limit activities, disrupt sleep, is costly. So all of this to say that this is important and it affects the quality of life of people living with sarcoidosis, and then we want to raise awareness about this issue. Now, how common is this problem in people living with sarcoidosis? So it's actually quite common. It's present in 30 to 40% of people with systemic sarcoidosis. So that's a lot. And in general, I believe is under-recognized and frequently misdiagnosed. So people may have these symptoms, are dismissed, are told that this is just anxiety or whatnot, and it's really something that is potentially treatable in 30 to 40% of people with sarcoidosis. So we should be aware that this exists. Usually, if this is going to happen, it happens within the first 3 years from sarcoidosis diagnosis, and usually happens when the sarcoidosis is active and not under control. The symptoms of the small fiber neuropathy do not respond typically to the first and second line of sarcoidosis treatment. So we know that when somebody's having a flare-up of sarcoidosis, typically steroids is one of the main things that are done, and methotrexate is often the first steroid-sparing agent that is used. This problem tends not to get better with those interventions, so we may need to change here. So this is some data from our studies. This is not yet published, where we analyze people with small fiber neuropathy that was biopsy proven. These are 48 cases. And just to show you a little bit of the demographics, most patients were women, but about a third were men. It's similar to sarcoidosis in general. The median age is in the 40s, and there is, it affects people in any ethnic and racial background, but it's in this case, more common in Caucasians and a good proportion in African Americans. And most people had a diagnosis of systemic sarcoidosis at the time of the small fiber neuropathy diagnosis, although for some of them it started at the same time. So it was sort of part of that initial presentation. It was just not necessarily recognized at the time. And I highlighted here the high rate of diabetes, which is 47% and 97% of people taking steroids. And I highlighted that because diabetes itself can be a cause of a small fiber neuropathy. So we don't know exactly if it's the diabetes in this population causing the neuropathy or the sarcoidosis, but I believe it's a combination of both that leads to the injury of the small fibers. Now, from that same casuistic, this is just to highlight the symptoms that people reported. So most people had pain and paresthesias, that's a tingling sensation, numbness. So it could be that is not painful, but just numb, like lack of sensation, burning, hypersensitivity, pain in the face, atypical chest pain. And I wanted to highlight here these three categories. So these are symptoms that are often dismissed but very frequent in people with sarcoidosis. This is fatigue, brain fog, and these autonomic symptoms that may include feeling dizzy upon standing up, or not sweating and getting overheated, um, bladder dysfunction, so difficulty voiding the bladder, or urgency that if you feel you have to urinate, you have to run. So the frequency of these is very high. So in people with small fiber neuropathy and sarcoidosis, 42% had fatigue. That's a lot. A third had brain fog. Half had these autonomic symptoms. So just highlighting that it's part, it's connected, and it's probably part of the same process. Now, what's the cause of this? Um, so small fiber neuropathy in sarcoidosis is interesting because it's different than what we understand from sarcoidosis everywhere else. Usually in sarcoidosis everywhere else, in the lung or in the heart, what's happening is that we have these granulomas, this specific type of inflammation called granuloma that goes and sits there in that organ, in, let's say, in the heart or in the lung, and causes inflammation at that level, and perhaps destruction of the tissues in around where this inflammation is happening. This is not what's happening with the small fibers. There are no granulomas when we looked at biopsies. So what we think is happening is that when there is inflammation elsewhere in the body from the sarcoidosis, these inflammatory cells release something called cytokines. These are, you can think about them as inflammatory signals or inflammatory proteins. And those are these IL-1, IL-2, IL-6, so they're called cytokines, and TNF. And these have shown to be elevated in people with small fiber neuropathy from other causes, which suggests that these cytokines are kind of toxic to the small nerves. And people even went further and looked at the skin biopsy, so that in the skin we can take a look at the nerves themselves and see the expression of the cytokines. And just long story short, we saw that people that have a small fiber neuropathy have increased expression, increased levels of these cytokines in the skin biopsies. So this really supports the idea that this process is driven by this inflammatory cytokine storm or this milieu of inflammation. And when we go back to sarcoidosis, because this is true in small fiber neuropathy from other causes, but if we go back to what's happening in sarcoidosis, we know from studies in sarcoidosis of the lung, from studies in sarcoidosis of the brain, that these cytokines are implicated in the disease, that are elevated in sarcoidosis, and that are very important to maintain the inflammation in sarcoidosis. So if we know that these proteins, these substances are elevated in sarcoidosis, um, and we know that those proteins are toxic to the nerves because we saw that here, then it's probably the cause of the problem, but that's not fully proven just yet. So lots of research going on, including my own. But so that's what the cause is thought to be. Now, how do you diagnose this? So there is a questionnaire. This is available online called the Small Fiber Neuropathy Screening List. This is a questionnaire that ranks symptoms that are present in small fiber neuropathy, including pain, symptoms of that dysautonomia. So it's asking about palpitations, about problems with bowel movements, with urination, about muscle cramps, about chest pain, dry eye. So all of these are symptoms that are seen in small fiber neuropathy. And you can rank if this never applies to you, sometimes, often, always. And this has a numeric value, so we can calculate a score. So essentially, it's from 0 to 5 and 21 questions. And if you score more than 11, then it starts to get into this is suspicious for small fiber neuropathy. And if it's more than 48, it's well established that probably, most likely, you would have, meet a small fiber neuropathy if we were to do a skin biopsy. So this really is the first step. So screening for the symptoms and having compatible symptoms. So let's say you do this questionnaire and you come out in the probable or highly probable category. So then what? So the diagnosis is confirmed with a skin biopsy. So you, at this point, would go to your sarcoidosis specialist if you have the availability to go to a neurologist, so a brain doctor that has expertise in sarcoidosis. Then that's better. So you say, I have this questionnaire or I have these symptoms. I'm worried about small fiber neuropathy. Then they would do a physical exam where they would check the pain sensation with a pin. They would check your temperature sensation. They would look at your skin and see if, in those distributions that are usually affected by this problem, the sensation for pain and temperature is reduced. And if we have a good suspicion, then we can confirm with a skin biopsy. So the skin biopsy is essentially measuring how many small fibers you have in a certain area of skin, and if that is reduced compared to what it should be. And if it's reduced, then we say, okay, so there is indeed evidence of a small fiber neuropathy. There are other tests that are checking small fibers in other places, like the cornea with something called corneal confocal microscopy, which is yet, is still not widely available. It's only available in a couple of academic centers, so we're not really using it clinically used yet. And then the other component is checking if you do have dysautonomia, and that's done with a specific testing for sweating. There's something called QSART that can be used, or a tilt test to check cardiac function. So these are complementary, but really the confirmatory test we use is the skin biopsy. Often we do an EMG or nerve conduction study. This is a test of the nerves and the muscles, expecting it to be normal. So that sounds odd, but the reason we do it is because neuropathy that affects the large fibers, it's measured by this test. And that's the most common type of neuropathy in diabetes, for example. So if this test is abnormal, then we know that you have neuropathy from something, possibly diabetes or something else, and we don't necessarily need to do the skin biopsy. So usually we do this, is normal, and then we're like, okay, so it's probably a problem isolated to the small fibers. Now, this is how the skin biopsy looks like. So I wanted to put this slide just to communicate that although it sounds like a dermatology thing because it's a skin biopsy, it's actually a neurology procedure. It's usually done by the neuromuscular neurologist or some general neurologists do it. It's done in the office, doesn't require general anesthesia, doesn't really require stitches. It's three little pieces of skin that are removed, usually in one of your legs, in the thigh, and in two places more distally in the leg. And the test itself is pretty good, is at detecting the presence of a small fiber neuropathy, but it's not perfect. And the reason it's not perfect is because this process can be patchy. So there may be areas of skin that have the fibers affected and areas of skin that do not have the fibers affected, and that means that the skin biopsy may miss where the issue is, and it may come back normal, and that does not mean you don't have this. So we still go by the exam and the description of symptoms and the ruling out of other causes. Now, a biopsy result being positive tells me that the fibers are reduced, and it tells me, okay, yes, there is a small fiber neuropathy. It doesn't prove that it's due to sarcoidosis. And that's important because even in people living with sarcoidosis, an alternative cause, so another reason for the small fiber neuropathy, is seen in 20 to half of the patient, 20% to half of the patients with sarcoidosis. Most commonly, the issue is uncontrolled diabetes, which is a well-known cause of small fiber neuropathy, but there are other things that may contribute or even be the only cause. That's severe alcohol use can be toxic to the nerves, chemotherapy, certain chemotherapies, if there's been a history of cancer, can be toxic to the nerves. Some vitamin deficiencies, so vitamin B12, B1, even some minerals like copper, if they're low, can lead to small fiber neuropathy. And then this one, the vitamin B6, I wanted to mention that the excess, too much vitamin B6 can cause a small fiber neuropathy. I actually came across this recently with one of my patients, and it's relatively common that people self-medicate with multivitamins for health, thinking that it's going to help with their overall health. But actually, vitamin B6 is one of the few things that you can actually overshoot, and if you have too much, it can be toxic to the nerves. So it's an easy fix just to stop a supplement of B6 if it's not needed, and that if caught early can fix the problem. Then amyloidosis, which is something that we check in this, once we do the skin biopsy, we can check for that with a Congo red stain. Sjogren's, so some autoimmune disorders, specifically Sjogren's, can lead to small fiber neuropathy, HIV, lupus, Fabry disease, and thyroid. So all of these are disorders that are not sarcoidosis that can cause a small fiber neuropathy and just should be evaluated for when we're exploring this. Now, what do we do about it? So the management has comes in two flavors. One is what to do with the symptoms, and the other one is what are we gonna do to prevent this from getting worse from inflammation point of view. So for the symptoms, I said earlier that this does not respond usually to regular pain medication. So this is not a type of pain, the burning sensations, the tinglings, that is going to get better with Motrin or with Tylenol. So usually your go-to drug, the first line, is anti-seizure medications that have been studied in nerve pain. So that's gabapentin or pregabalin or carbamazepine. Gabapentin is usually the first line, and then we can also use antidepressant medications, not because of depression, your mood can be perfectly fine, but because we know that these antidepressants, specifically Cymbalta, I like a lot, and nortriptyline, are modulators of nerve pain. Now, these ones I don't use as often, the capsaicin cream and lidocaine patches or lidocaine cream. These essentially can numb the skin that is painful, and it works fine if the area affected is limited, but you cannot realistically use this in a large area of your body or in your whole body. So that's why medications like gabapentin are usually used. Now, these are, just for your reference, the usual medications we start, and the doses, and the side effects. So I'm going to focus first just in these first line therapies. So the gabapentinoids, those are gabapentin and pregabalin. there's a wide range of doses. So you can see that, the minimum we start is 100 milligrams 3 times a day, but we can go as high as 3,600 milligrams in a day. Now, we don't start people in high doses because this medication specifically can cause brain fog and can cause fatigue. Those are the two main symptoms that people complain about. And this is a disorder that is already associated with fatigue and brain fog. So we usually start slow and we bring it up gradually over time. This is a very good medication for nerve pain. If this fails or is not tolerated, or it causes other problems like swelling, which is something, swelling in the legs is one of the side effects too, then we often move to pregabalin or Lyrica. Works very similar, but it's a different molecule, often better tolerated. Now, sometimes we need to add a medication in the antidepressant family, or if this is not tolerated, we just start there. The one I like to use more is this one called duloxetine. And I like to use it because it's a little bit activating as opposed to the others that cause fatigue. So if somebody has fatigue, this is a good medication that may help with fatigue and pain. And it works very well in combination with either gabapentin or pregabalin. It can cause a little bit of nausea, it can cause a little bit of constipation, and it causes dry mouth, which is something that already can happen with small fiber neuropathy. So, all of these medications have potential side effects, but if somebody's having constant burning pain, is worth it. And I do see that it improves the quality of life of people quite a bit. Now, the second line that I have here are opiates, and I tend not to go there because they just don't work as well for nerve pain. So we typically just try, a couple of medication options in this category, and that's enough for most people. If needed and there is uncontrolled severe pain, opiates do have a role, and we use them when we need to, but I'm not a fan of starting there for chronic pain. All right, so that's symptomatic treatments. Now, how about immune treatments for this? Because we said that is an immune problem from the cytokines, right? So what are we going to do about it? Now, the answer there is a little bit, so the fair answer is we don't quite know yet. There are some small studies that have been done, retrospective, which has, its limitations. But the studies that have been done show that using IVIG or anti-TNF alpha agents, and those would be Remicade, infliximab, or Humira, and biosimilars, appear to be beneficial in treating the symptoms. So IVIG, we'll talk about a little bit more, is an infusion given through the IV, usually over a couple of days, to be repeated once a month. So it's quite a commitment. But in this report, at least a small study, 75% of people got better with it. And with the TNF alpha treatment, 66% of people got better. And now in combination, 70% of people got better. So I think, with something as debilitating as this, uh, now that we have studies that show that this offers some benefit, it's worth trying. So at least I do offer these therapies for small fiber neuropathy associated with sarcoidosis. You can see from those percentages that it's not 100%, so not everybody responds, but I think it's worth a trial. Now, what's IVIG? So this is it's essentially a blood product where they take antibodies from multiple blood donors, they pull them, and then they give you that as an infusion, and it acts as a modulator of the immune system to reduce inflammation. It's usually not my first go-to because it does not treat the systemic sarcoidosis. So if you do have cardiac or lung sarcoidosis or liver sarcoidosis, it's not going to help with that. So it may help with the small fiber, but it's not going to help with the systemic sarcoidosis. So you may still need an additional treatment regardless. Um, the side effects most commonly are a headache or an infusion reaction or a flu-like feeling the days that you get it, and there is an increased risk of blood clot. Now, if nothing else is working, we do try this, so it's an option, but it's not my first option. One thing that so that we do use a lot is infliximab. And in my personal experience, infliximab and adalimumab, that would be Humira or Remicade, do work, and often people do feel better, at least stop progressing. And that's consistent with that prior study that I showed you before. But the jury is still out. And I say that because there was a small study, much smaller than the one that I showed you before. So this one that said that this work included 143 patients. This one is way smaller, it's just 36 patients. But this is a different group. They used infliximab, and they saw that it does decrease inflammation, but the symptoms of small fiber neuropathy persisted. So this group said, in our study, it didn't work. What I think is larger studies are needed, and more information is needed. But since there is evidence that this can help a large percentage of patients based on our studies, I still offer it and still use it. Now, in our patients, so that's from that same study that I was showing you of the 43 patients. So again, it's small numbers, but in this case, 13 patients were exposed to infliximab and 15 to Humira, and about half responded. And there were 4 patients that were treated with Actemra, which is a different medication, it's an IL-6 inhibitor, and 3 out of 4 responded. So I think we're still learning about this, and there's more research to be done, but I think there is hope that some of these treatments may help at least a subset of patients. And since now we have a few that may work, then that means that we have options. And if something doesn't work, then we can try something else. And I wanted to mention a little bit about fatigue, because we saw that very large percentage of fatigue associated with small fiber neuropathy. So sarcoidosis associated fatigue happens in 50 to 80% of people with sarcoidosis. So chances are that if you're living with sarcoidosis, you've experienced this, and it persists with, when disease activity is better controlled. So it's poorly understood. It's not really well correlated with lung function, so we cannot really blame it on that. And it may be that it's associated with the small fiber neuropathy based on just this high percentage. Similarly to the concept of the screening form that I showed you before, there are assessment scales that are validated in sarcoidosis to measure fatigue. This one is called fatigue assessment scale. This is the link where you can get it. Um, and it's just a screening to see if you have significant sarcoidosis associated fatigue. And it's important to identify this because study after study, this is a table just showing various studies, what they did, what they measured. All of them show that this untreated fatigue in patients living with sarcoidosis decreases quality of life. So we need to do something about it. And what we need to do is try to understand if this is due to the sarcoidosis itself or due to something else. So is this due to the small fiber neuropathy? Is it due to the pulmonary component or the cardiac component or the hormones being affected in sarcoidosis? Or is it due to other things that may cause fatigue in somebody even without sarcoidosis, like sleep apnea or anemia, or alcohol use, or the thyroid being affected, or importantly, depression and anxiety that are not well treated. So all of these things come into play when you go to a neurologist and you say, I have fatigue. So these things should be screened for. And what we do is we try to first get the sarcoidosis systemic disease under control. We check for other causes. We check the thyroid function, evaluate, for depression. And if that doesn't do it, then there are stimulants that can be used to help with fatigue. So that exists. That those would be things like modafinil, for example. Brain fog is also very common in people with small fiber neuropathy. We see cognitive symptoms in 25% of all patients with sarcoidosis. And again, there's a study showing that this affects quality of life that is under-recognized, and it's associated with depression and fatigue and small fiber neuropathy. The way we quantify this is we do neurocognitive testing to see if it's, objectively there's something wrong with cognition, and we go from there. Probably the workup of this includes an MRI, but at the end, controlling the inflammatory process of sarcoidosis helps with the brain fog too. There's been studies looking at the TNF-alpha inhibitors, including infliximab and Humira for fatigue and cognitive issues. Some report some benefit, but there's not really a high evidence study. So I think we're still not quite sure if that's the right thing to do to treat, let's say, sarcoidosis fatigue or sarcoidosis brain fog by itself with TNF-alpha inhibitors. But we know that if there is evidence of active disease somewhere else, getting that under control can be beneficial. All right. Thank you. And thank you all for your patience and with the difficulties with the Zoom. So I'll stop sharing my screen now and we can open the floor for.
Yes, thank you so much, Dr. Barreras. I want to check with you. What is your time limit? Do you need to head out? I know you're in California, so.
I will need to head out, but we should, they
Okay,
normally
I'll ask for sure the questions that we got from the people that are live here, and then I'll try to do a summary. We got so many questions. This is definitely a topic a lot of people will really interested in, and I know I have quite a few people asking if you would be willing to share the slides that I could send out in the email afterwards, so you and I could talk about that. Okay, so first question. For small fiber neuropathy treatment using infliximab, what are some medications that can be used to help fight against developing antibodies? And along with that, are there any other CellCept other than CellCept and methotrexate?
Yeah, so that's a good question. That applies to small fiber neuropathy, but also to sarcoidosis in general. So if your treatment plan involves Remicade or infliximab or one of those, one of the things that can happen is that you develop antibodies against the drug, and what happens when that develops is that the drug becomes less effective because the antibodies can bring the levels down, but also it increases the chances of infusion reactions, allergic reactions. So to prevent that from happening, what we do is we combine the infliximab with a low dose of something else. So a low dose of methotrexate, maybe not as high as you would need if methotrexate was your only maintenance treatment. So methotrexate is really your go-to at a low dose. If that doesn't work, then we typically use a little bit of Cellcept, but azathioprine can also be used. Now, it's not a must. You can use infliximab on its own. So there are people that don't tolerate these other drugs, or they don't like them, or for other medical reasons cannot use them. It's okay to use infliximab alone. It's just that maybe like eventually that complication may happen.
All right, thank you. Next question, is it true that a patient diagnosed with neurosarcoidosis will continue to have tingling, pins, needle sensation, even if they go into remission?
They can. So essentially, you can think about this as a scar in the nervous system. So there is inflammation, things are on fire. You treat the inflammation, and things should at least stop getting worse from there. You start a treatment, that being your methotrexate or your infliximab, to prevent additional attacks of inflammation from happening. But if there was already nerve damage from either in the spinal cord, in the brain, or in the nerves, some of that may recover depending on the degree of damage, and it may take time. So the brain and the nerves, repair in over months, not days. But it may be that there is a scar that is left that causes permanent damage, and then the sensations may continue.
Okay, thank you. Yeah, that makes sense. Okay, can you talk about, is there any reason to find out if you have small fiber neuropathy or large fiber neuropathy? Is there a reason to discover the difference, or are they treated pretty similarly?
Good question. So I do think it's worth it to discover the difference, because a large fiber neuropathy, which is more common in the general population, it's more likely, let's say, associated with diabetes, or it could be something completely different, like a CIDP, Guillain-Barré, depending on the symptom. If there is large fiber involvement, that may point to a different cause, and the treatment may be different. Now, if you do an EMG and you already prove that you have neuropathy and you have sarcoidosis, that large fiber component can still be from sarcoidosis. And then the question really is if the skin biopsy is worth it. Because if we are trying to control the sarcoidosis anyway, and we're going to try to control the other factors, the diabetes, it may be that it's not as important to prove that the skin biopsy is abnormal if you already proved that you have neuropathy. But if the nerve conduction study is normal and we really at this point are just going by the description of the symptoms, I do think it's useful to try to prove that we're right and it's actually small fiber neuropathy. Now, like I said, a negative biopsy does not rule it out. So it's really the attempt to prove this has two purposes: to the sanity check that we're actually like diagnosing and treating the correct thing, but also for insurance. I wish that it wasn't a factor, but sometimes if you don't have proof, they won't approve your treatments for the small fiber neuropathy.
Yes, insurance. We have lots of conversations about that. Okay, thank you. Okay, this one had to do with when you were talking about the IVIG, is what I wrote down. Do you have to stay on the treatment, or is it something that you can come on and off and do periodically?
You don't have to stay on. So IVIG is usually given as a monthly infusion, but once things stabilize, let's say you were in a crisis, you'd start IVIG, things get a little better, you can space it out. Sometimes we go from every 4 weeks to every 6 weeks. And then it's reasonable, and we often do trials of stopping the treatment and see what happens, because it depends on the inflammation of the sarcoidosis in general. So we can, if we control the inflammation somewhere else, and now the IVIG help, sometimes people are able to stop it. So not necessarily you need to stay on it.
Yeah, perfect. Thank you. Can you talk about ozone therapy and what you know about its effect on sarcoidosis?
I don't know much about it. So that's my honest answer. So not my area of expertise. I've heard from patients as anecdotes that they went and got it and perhaps saw benefit, but I don't really understand the mechanism of why it would help. So I think there's more science to be done.
Perfect. Thank you. What is the differential between SLE sarc and what is the differential if the scans are not showing lesions or granulomas?
So what's the differential if for the symptoms or of the difference?
I'm
So
not
for
sure.
SLE, sarcoidosis, and so SLE is lupus.
Okay.
So if the question is, how are those different, or how do you know which one is causing the neuropathy? It can be tricky to find out. So essentially, somebody has symptoms, and that can be explained by sarcoidosis leading to the small fiber neuropathy or lupus leading to small fiber neuropathy. There are markers in the blood that can be measured for lupus markers to see if the lupus is active, and we do the same with sarcoidosis, right? We would do a PET scan, or we would do certain blood tests to see if that's active, and then we try to uh, to blame it on one or the other and control both diseases if both are present.
Perfect. Thank you. Okay, almost done. So can you talk about are there things that people with small fiber neuropathy can do that will help slow down the progression or reduce their likelihood of it getting worse?
Yes. So in general, and this is true for the nervous system in general, the more you do is like use it or lose it. So exercise and physical activity, it's good for you. Non Like stopping things that we know that are harmful to the nerves. So smoking cigarettes, toxic substances, not to do the excess of vitamin B6, to avoid excess alcohol use. Doesn't mean that you cannot have a beer every now and then, but maybe not have 2 bottles of tequila every night. So those things that may aggravate the problem, and ultimately trying to get the sarcoidosis itself under control with appropriate therapies.
Yes, thank you. That's very helpful. Do you know of a resource where people can participate in trials for neurosarcoidosis?
Yeah, so clinical trials, you can find them in clinicaltrials.gov. That's the government website where any clinical trial can be, needs to be registered. So you can search for the word sarcoidosis and you would find any trial that is going on. Clinical trials, by definition, are studies where they are doing an intervention. So these are the where they are testing a new drug or they are, doing something to you. There's another type of study where they don't do anything to you, but still a research study where we perhaps collect blood or collect information and we learn about these diseases. We measure things without doing an intervention. And that is, we are specifically doing research in small fiber neuropathy and sarcoidosis, and we're happy to get, volunteers. So we are in LA, but we're looking at measuring blood and pain scores just to understand this better because I think we still have a way to go to try to clarify if the symptoms are really from the inflammation, from what part of the inflammation cascade and whatnot. So in sarcoidosis in general, I think there are many studies that are still in that phase. And those
Yeah.
studies, earlier studies, are important to know which interventions are worth, going into a clinical trial.
Yeah, that makes sense. And so if they want to volunteer for the research you're doing, how would they do that?
Yeah, message me, call me. I think there I put the phone number to the clinic.
They're on the
So
side.
so we, the study just entails a blood draw every couple months and coming in just to answer these questionnaires, a small fiber neuropathy list, a physical exam. It really helps us out to understand these disorders, but it's not a clinical trial, so you wouldn't get a treatment. Um,
Okay. So it's information gathering, not a clinical trial, but it would still help you. Okay. And I'll make sure that to put that in the email. I'll make sure to put it in the email that your number. Okay, yes. Okay, last question. Is there a treatment for TMJ and is it part of small fiber neuropathy?
so TMJ itself, so that's the temporomandibular, a jaw problem that it can be very painful. Is not really part of small fiber neuropathy, but the symptoms can be very similar, so it's tricky. So you can have facial pain in small fiber neuropathy and sarcoidosis that may be misdiagnosed as TMJ. So if it's through the TMJ, then it is not related. But the question would be, is it actually TMJ or this is missed small fiber neuropathy? Because if you have pain in the face and have sarcoidosis, it may as well be small fiber neuropathy.
Perfect. Okay, thank you. Thank you so much for staying late, everyone. Thank you for your flexibility and for coming and joining us on this crazy journey. I know we didn't get to all the questions that were sent in beforehand, so please, if you would like to make sure your question got answered, then go ahead and email me at abigail@lifeandbreath.org, and I will do my best to get a doctor to answer it. Thank you all. I will get this replay out with her phone number and the slides. And yes, Dr. Barreras, we cannot thank you enough for coming. Like I said, the interest in this topic was so high, and I'm so thankful that you took the time and effort and are helping us learn about this disease.
Yeah, no, happy that to see a lot of people interested, and I will send you the slides so you can.
Thank you. Yes, we have support group. We have a support group that meets twice a month on Thursday night. And Dick is our host for that and does a great job. It's all just patients. We don't record anything. So it's just a time where you can meet with other sarcoidosis patients and support each other. And it's a really, really encouraging place. So thank you all. Have a wonderful Wednesday night. Thank you, Dr. Barreras. Thank you, Dick, for helping me. And we will see you all either at support group or next month.
All right, bye, everyone.
Bye.